We're moving on to the last talk of the session, which will be by Colonel Pradeep Kumar. He's a professor of ophthalmology from the Army Hospital, New Delhi. So he'll be talking to us on Brolucizumab in pachychoroid spectrum. Over to you, Pradeep.
Thank you so much for the opportunity to present. Firstly, my job has been made very simple by Dr. George. So he has told us all about identification and how to go about treating the pachychoroid spectrum. I will begin with why we are talking about Brolucizumab today. We all believe that it is the most efficacious anti-VEGF we have today, but yes, there are safety concerns. And while the Western world has adopted faricimab, we are yet to see the durability set in the first or second injection. It takes time for the durability to set in, and the peak efficacy as per us has been lower. Now, how to prove this point? So what has changed in our practice in past couple of years is that we have moved to biosimilars compared to innovator in terms of ranibizumab usage, and post-COVID, all of us have learned the importance of longer inter-injection intervals, and this is how our practice change at Army Hospital R&D. From giving close to about 3,500 injections in 2021, our total number of injections are gradually reducing. And it is not so that our number of patients are reducing, our number of patients are actually increasing. But this has happened because one, the ranibizumab part has been taken over by the biosimilar, and two, there has been an influx of aflibercept, brolucizumab as well as faricimab, which are effectively reducing our total injection load. As you can see, we started using brolucizumab way early in 2021 due to our 2 RCTs which were going on, and they have continued to find a place in our clinics despite the safety concerns. The faricimab usage started last year and is gradually picking up, and it has actually helped us in reducing the total number of injections by close to about 3/4 of what we were injecting initially. So these are initial take-home messages from these slides, that as ranibizumab has seen its way out of our clinics, in couple of years we might see a similar trend with aflibercept, though aflibercept HD will pave a new way forward, and the perceived severe adverse drug reactions of brolucizumab in our hands have been 6 in 2,876 cases. And we can say that none of our patients have gone to poorer visual acuity from where they initially started in any of these 6 cases. So our initial work with brolucizumab got published in 2022, where we spoke about neovascular AMD. In this case, we had taken treatment-naive neovascular AMD cases, and the best corrected visual acuity at the end of 52 weeks was a shade better than aflibercept, but it was not statistically significant. What was statistically significant was a reduction in central macular thickness. The molecule brolucizumab had a much greater drying effect, and this drying effect was specifically seen in the subretinal fluid compartment. I'll give you one example of a pachychoroid spectrum disease in this gamut of neovascular AMD diseases, where right after one injection, 18 May 2023, this patient has been on continuous follow-up, continues to maintain 6/9 vision with a little bit of metamorphopsia, and has not required a second injection. So this molecule is pretty strong. Now, after 104 week compiling 2-year data, we have shown that the inter-injection durability is 12.7 weeks with this particular molecule. Though we are continuing with our faricimab study, we have not been able to achieve this figure yet with faricimab. There were just 3 adverse drug reactions in our neovascular AMD subset. So the question which was frequently asked, why we did not do a subset analysis of PCV cases? So we sat down on it and started looking at the literature, which told us that though the visual improvements with aflibercept and brolucizumab are similar in PCV cases, the regression of polyps is greater, and more evidence suggests that with aflibercept, just half of the patients achieve this regression, while it is close to about 3/4 with brolucizumab. So the superior anatomical outcomes were established in other studies also. In our subgroup, we could identify 19 ICGA proven PCV cases in brolucizumab subset and 17 aflibercept subset, which were about a decade younger than rest of the population in our study. And this was our methodology that we followed, and the best corrected visual acuity changes show that there is an early achievement of better visual acuity with Brolucizumab, though both the molecules try to become similar by about 52 weeks. Until about 104 weeks, the effects remain. From 52 to 104 weeks, these patients were kept on PRN regime rather than a strict 4-weekly mandatory follow-up. In the central macular thickness group also, we realized that in first 12 weeks, the drying effect is much higher with Brolucizumab, which is retained till 104 weeks. Now the key issue is how many number of injections are given. We realized that with aflibercept, the number of injections which are given remain much higher till about 104 weeks. So our inter-injection durability in PCV subgroup has been a little lower than the classical neovascular AMD subgroup at about 9.9 weeks, say about 10-week interval. Now we also started thinking that what about the rest of the pachychoroid spectrum? Why we have not investigated this molecule in CSCR? So we looked at the evidence and people were already talking about an impact of Brolucizumab in non-calcitrant CSCR cases. The largest study came from China where they had 3 arms comparing PDT versus Brolucizumab versus aflibercept, and they also showed that with Brolucizumab they were the faster drying. So this we like to show our series of CSCR cases which were chronic, had a central leak within 1000 microns of fovea, and there was no CNV on either ICGA or OCTA. In our first case, we achieved a partial response with a small drying effect. But in our second case, this was the cockpit crew wanted to go back to duty faster. These are various segments of the same macula. The macula became completely dry at 14 days and has remained so since then. So we have had 9 such inclusions in our series, out of which 7 have shown drying effect, 5 with complete drying, 2 with partial drying, 2 patients did not respond, and a single dose of Brolucizumab was sufficient to cause the drying, and we have not had to inject a second dose in any of these patients. Lastly, we also wanted to understand that what is this molecule causing in cases of pachychoroid neovasculopathy. So the evidence shows that when PNV cases are treated, almost 64.7% showed complete resorption of both IRF and SRF, while about 1/4 cases did not respond completely. So we tried to look at isolated PNV cases which were being treated only on the indication of metamorphopsia and diminution of vision, and on ICGA we have not seen polyps in these cases, and on OCT there were no sharp or thumb-like PETs. 13 such cases could be identified in our case series. This is a retrospective data. We have identified an inter-injection interval of about 17.6 weeks. So once you treat PNV cases with Brolucizumab, you find an even larger inter-injection interval compared to neovascular AMD and PCV cases. So to conclude, I like to say that Brolucizumab is efficacious in pachychoroid spectrum. The higher inter-injection interval in PCV, the confidence comes from our RCT data. It tells us that it is close to about 10 weeks inter-injection interval. We are not talking here about the increased best corrected visual acuity gains because they were not statistically significant, though I'll say they were about 0.3 logmar higher. And there is a higher inter-injection interval in PNV based on our retrospective data. And for CSCR, though we have a very limited data set today, but when a patient, you have a central leak and micropulse laser is not working in these cases, this is one molecule you can give a try.